Good afternoon, everyone. Hopefully everyone can hear me. My name is Yvette Cozier. I'm a member of the Black Women's Health Study research team, and I'd like to welcome you to the second in our 25th anniversary webinar series. Thank you for joining us this afternoon. Today's topic will be COVID-19 in Black women's health. And I'd like to just start with a couple of housekeeping issues. If you'd like to ask questions during the presentation, please click on the Q&A button that should be at the bottom of your screen. If you're joining us through, oh, there's an echo. Sorry. If you're joining us through Facebook, please post them in the chat log on Facebook. So some people are hearing an echo, others not. So maybe BWHS, can you mute, please? Okay, great. Okay. So as far as technical difficulties, please let us know in the chat button. I think today we're all having a little bit of technical issues. Just to let you know that we are recording this webinar as we did our last, and the recordings will be available on our website at the www.bu.edu/BWHS. So I'd like to just start and introduce the panelists today. You've already met me, but I'd like to introduce Dr. Michelle Albert, who's professor of medicine at University of California in San Francisco. She's also an investigator with the Black Women's Health Study and co-investigator of the Black Women's Health Study COVID-19 study. And we're also joined by Dr. Ellen Grant, who is one of our advisory board members. She is the Senior VP of Say Yes to Education and former Deputy Mayor of Buffalo, New York, as well as the former Commissioner of Mental Health for Erie County, New York. Next slide, please. We are also really blessed to be joined by another advisory board member for the Black Women's Health Study, Dr. Linda Clayton. Dr. Clayton is a gynecological oncologist. I believe she was the first African-American woman to be trained in that subspecialty. She is an accomplished educator, a medical educator, and a medical historian. She is co-author of a two-part compendium of African-American health called American Health Dilemma. Volumes 1 and 2 were both Pulitzer nominated, and really give the entire history of African-American health. Thank you for joining us today, Dr. Clayton.
Thank you.
Great, and next. So at this point, we're going to switch to my colleague, Dr. Michelle Albert, who's going to give an overview of the topic of COVID and how it has impacted not just Black communities, but certainly our health and the planet, because this is indeed a global pandemic. Michelle, are you able to? Okay, here we go.
Thank you, Dr. Cozier. I am thrilled to be invited to be part of the webinar today. As you heard, I have a longstanding relationship with the Black Women's Health Study. I am in San Francisco now, but I spent 16 years in Boston, where I worked closely with Dr. Cozier and team. So today, I'm a cardiologist. So I'm going to be talking to you about COVID and race and ethnicity with somewhat of a cardiovascular spin. So let's advance the slide. Next slide. So certainly the news broke in early April, actually, exactly on April 8th, related to the terrible impact that COVID-19 was having on communities of color, and especially specifically the African American community. One of the roles that I'm in currently is that I serve as president of the Association of Black Cardiologists. And our organization at the time, on April 8th, which is why I can remember the date, actually did the first webinar focused on race and COVID-19 in the population. So what about race? If this slide demonstrates that Black, Latino, and Indigenous persons have been disproportionately affected by COVID-19 compared to others. Certainly Blacks, Latinos, and Indigenous individuals have had higher hospitalization rates, although the in-hospital mortality based on race is actually not different by race ethnicity. But overall, 1 in every 900 or so Blacks have died from COVID-19 compared to about 1 in every 8,000 or so whites. So these are staggering statistics. And this is why this is important to us as Black women. Turns out there's, and you'll hear later, we do need to understand what COVID-19 is doing among Black women. This is a slide that just shows, one of the pushbacks that you get is that, well, yeah, Blacks, have had a disproportionate impact relative to their population prevalence related to COVID-19, but more whites have actually died of COVID. And this is what's shown in this slide, which is in the bottom part of the graph. The dark blue represents, whites, and the green, the bright green represents Blacks. But again, it's the proportionate prevalence in society wherein Blacks have outpaced any other racial or ethnic group. And the other thing that this slide demonstrates is that actually over time, more people relatively have died in the various racial and ethnic groups. These are data from New York. So those of you who are from New York, showing that Blacks or African Americans have the highest prevalence, whether they were not hospitalized, or died from COVID. And these are data from earlier in the pandemic, and these still hold true currently. So when you look at the case fatality rates, again, in New York, which was, sort of ground zero, no pun intended, for the surge, again, you see the disproportionate impact in people of color. One thing that is of importance to note is that whereas, the risk for COVID-19 mortality is higher as you get older, so people with chronic medical conditions such as cancer, cardiovascular disease, diabetes, obesity are at higher risk of dying from COVID and having COVID-related complications. What this slide shows you is that even after you adjust for age adjustment actually widens the mortality gap by race ethnicity, such that younger Blacks and Indigenous people of color are dying from COVID-19 at higher rates. And actually, if you compare the rates at which younger Blacks are dying from COVID-19, their mortality rates are actually higher than that of whites in every age category. So if your kids walk around saying, oh, we're younger, or you're walking around saying you're younger and you're not gonna, have complications, please wear your mask and socially distance. So why are these data the way they are? Pathways through which COVID-19 disproportionately affect people of color, especially Blacks, are related to segregation. Okay, segregation results in weakened neighborhood and community infrastructure, results in multi-generational households, unequal access to employment, which results in underemployment, results in differences in access to care, especially access to quality care, and also promotes exposure to elevated levels of the virus, as well as other chronic and acute stressors. This is a slide. These are data from the American Journal of Preventive Medicine. And I don't want to delve into the details too much here, but it's looking at social vulnerability and its relationship to COVID-19 case count. And basically, on the far right-hand side of the slide, you see a 9.13 higher odds of social vulnerability based on minority status and language. So why is this the case? We had the opportunity, I penned this perspective, which was published in Circulation, that talked about at the heart of the matter, unmasking and addressing COVID-19's toll on diverse populations. And this is a slide actually showing that COVID-19 health disparities are driven by socioeconomics, access to care, disproportionate burden of comorbidities among Black and Brown populations, elevated levels of discrimination, unemployment, cultural factors, and I put biological factors in quote. And so potential solutions are listed on the right-hand side of the slide. These include expanding housing, making dormitories available, et cetera, hotels available for social distancing, especially in the surge, providing food. This is particularly important for the sick and elderly among us who are more vulnerable for COVID-19. Expanding healthcare coverage, which is what we're fighting for, one of the things we're fighting for with our elections right now, supporting education. COVID-19 has resulted in a lot of social distancing and digital divide, which has always been present. Many Blacks get their internet by phone as opposed to by computer, and we've moved to telemedicine and digital learning. And there's disproportionate differential access to these things. Protecting workers. Many Blacks are essential workers, whether you're in healthcare, whether you're working in a supermarket, whether you're cleaners, whether you're working in public transportation. And this is regardless of education level. Developing policy initiatives to address health disparities that are coordinated at the local and federal level. We've seen where the lack of coordination has resulted in more deaths in the United States related to COVID-19, and expanded and easily accessible testing, as well as safe and viable transportation options. Another thing that's really near and dear to my heart is, as a cardiologist, the reason that the death rates are fairly, the cause of death, I should say, related to COVID-19 in many actually is cardiovascular. Once you develop fluid in your lungs, the heart is inflamed, you get blood clots, there are abnormal rhythms of the heart. Many COVID patients had developed stroke, heart failure, et cetera. And in kids, you've heard about the multi-system inflammatory syndrome in children. And certainly what we're seeing from a clinical perspective is that the COVID long haulers, where even if one survives COVID, we're seeing that as many as 50% of individuals have heart damage or some problem related to their heart. As a healthcare worker, I care deeply about this particular study. This is a study out of England, looking at the risk of COVID-19 among frontline healthcare workers and the general community. And what it does is that it looks at the relationship between COVID and the general population, the interplay between healthcare workers, COVID, general population. As you can see in the pink side of the slide compared to the blue, which is the general population, pink being healthcare workers, that in the UK and in the United States, obviously healthcare workers are more likely to be positive for COVID-19. And this was a study that was done using apps. And this slide, what it does show is that if you look at race, ethnicity, healthcare workers, and COVID-19, in the red circle or red oblong circle you'll see here, is that if you are non-Hispanic white compared to Black, Asian, or other minority, you'll see that as a healthcare worker, you're more likely to test positive for COVID if you happen to be Black, Asian, or other minority person, whether you're in the UK or in the United States. So what should we learn about COVID as we move forward? I have these slides here to close out this presentation about meteorologic disasters, COVID-19, and race ethnicity, because I think we can learn from this as we think about how to take care of ourselves and our population related to COVID. These are data from Hurricane Katrina, showing in the blue on the left-hand side of the slide, pre-Katrina and post-Katrina. The risk of myocardial infarction actually tripled and has stayed that way since Hurricane Katrina came on shore to now. Oftentimes when we have disasters like hurricanes, we think about, the risk of drowning and flooding and so forth. We think about the immediate effect, but we're not necessarily thinking about the long-term, especially cardiovascular effects. This higher risk of myocardial infarction is driven in red on the right-hand side of the slide, post-Katrina, by smoking, underemployment, being underinsured, the things that sort of people lose when they have a disaster. What you're actually seeing also happening in the COVID-19 pandemic. The other issue relates to post-traumatic stress. We know that depression, anxiety is actually fairly high in the population pre-COVID, and post-COVID, the prevalences of those conditions is also rising. We see that post-Hurricane Katrina, pre-Hurricane Katrina, PTSD screen was significantly more positive in Blacks versus whites. And then post Hurricane Katrina, those trajectories just continued. And that pre-hurricane mental health of Blacks was worse, and post-hurricane social support was less. So we know that we have to have a trauma-informed, approach in addition to the cardiovascular approaches and post-infection approaches to taking care of folks with COVID-19 and their families for that matter. So I just want to end by highlighting a couple of myths as it relates to COVID-19. One is that Black race is not a predictor of COVID-19 complications because it's all about socioeconomic status and poverty. And yes, racism is actually what drives disease outcomes and disproportionate outcomes by race ethnicity. Lower socioeconomic status is associated with poorer health outcomes, and Blacks have diminishing returns on higher socioeconomic status. So we know that more educated Blacks are not immune from this disease process and the complications. We know that Blacks who are higher socioeconomic status still outpace whites who are of middle income in having complications from myocardial infarction, for example. We know that racial discrimination limits education, economic, and healthcare access at all levels of socioeconomic status for Blacks. And we know that segregation persists regardless of income or education level. We know that the COVID-19 pandemic, as it relates to race and ethnicity, and Blacks in particular, is not limited to the shores of the United States. These are UK ICU data, which show that there's a COVID-19 death disparity by race in England as well, in the UK as well. Minorities comprise about 33% of critical care patients, but only make up 13% of the population. So what are the take-home messages? It is that adversity related to COVID is common and is unevenly distributed. And that's true regardless of the socioeconomic status you have if you're a person of color, especially Black. COVID-19 has amplified longstanding adversity experienced by racial and ethnic minorities. And that understanding the COVID-19 experiences of Blacks in general, and you'll hear Dr. Cozier talk about a study that we're working on together, will play a critical role in targeting solutions focused on mitigating viral risk in minority communities. And the Black Women's Health Study will play an important role in understanding COVID-19 risk. Thank you.
Thank you. Thank you very much, Dr. Albert. I will talk about the Black Women's Health Study, COVID study, but I want to shift just a little bit and bring in the voice of Dr. Ellen Grant, who, again, as I mentioned before, is a mental health professional. Dr. Grant, would you like to add some to what we've just heard in terms of the burden that COVID has on mental health? Oh, we can't hear you. Wait. Let's see. Try again. Can you? No, I can't hear you. Well, hold on. While you're going, while we're getting your audio going, I'm going to swing to Dr. Clayton. And perhaps, Dr. Clayton, are you still there?
Yes, I am. Can you hear me?
Yes, I can. Would you like to give us a historical perspective on COVID, but also on how this fits in the historic picture of African American health?
Yes. First, I'd like to thank Dr. Albert for such an impressive and excellent presentation. From an historical perspective, one of the things that we need to keep in mind as it relates to the COVID pandemic and other issues related to health and healthcare in the United States is that what we see today as far as health disparities and unequal treatment relates to the continuum of poor health care and health outcomes for Blacks in America. When we arrived here in 1619, all the way through the abolition of slavery in 1865, it was demonstrated that the slaves actually had the worst health care and the worst health outcome than the planters and the whites. And we could understand that because there was really no health system in place for Blacks. There was a evolving system for whites. However, Blacks' mortality rates were sometimes as high as 40, 50, 60% or over from all disease processes. However, infectious diseases, viral diseases always took a toll on Blacks worse than it did the planters or the slave owners. Then from 1865, after the abolition of slavery, during Reconstruction, all the way up basically until the 1960s, there was the segregated health system in the United States. So for people who didn't have any access, well, those Blacks certainly had worse health outcomes. But in the segregated system, there were poor facilities for most Blacks. At one time, there were up to 14 Black medical schools in the United States. They trained Blacks to become doctors and nurses and healthcare providers. However, most of them were in the South. So the health and healthcare of Blacks was very disadvantaged compared to whites all the way up until the 1960s through the segregated health system. Then in the 1960s, when healthcare facilities were desegregated by law, we still have not gained equity or equal access to health and health care, be it for pandemics or just regular care. So throughout our history, we as Blacks have had the worst health care, the worst health status, and the worst health outcomes than any other population group in the United States. Now, having said that, if we just jump forward to say the 1960s till now, even though hospital facilities were desegregated, we still do not have access to care. That becomes important when we look at COVID and our access to the same level of care. So we know there are several major things that have contributed to health and healthcare outcomes throughout history. The social determinants of health, which Dr. Albert has spoken to us about. The health system itself, she's talked to us about that. The health system is divided into 12 components, and we don't have time to go through all 12 components, but we are familiar with hospitals. That's one component. We're familiar with insurance companies. That's another component. We're familiar with the medical schools, et cetera. Outpatient facilities, so pharmaceutical. In America, Blacks do not have equal access to all of the components in the healthcare system that we mentioned. But even if you had access, are those facilities available to you? Can you afford it? Do you have adequate insurance as a Black person. So access, availability, affordability, adaptability, all of those kinds of variables are compounded with whether you actually have poor social determinants or actual adequate social determinants that drive your health care. So putting all this together, it contributes to the poor health status, the poor overall health status and outcome for Blacks. When it comes to COVID, our experience with social determinants, the health system itself, all of that parallels what's been going on for 401 years. Then you look at things within the health system itself, unequal treatment, biased clinical decision-making, lack of cultural competence, all of those kinds of things historically and contemporaneously contribute to poor outcomes for Blacks and other disadvantaged population groups. It's not just Blacks. So in a nutshell, that's sort of a panoramic view of the fact that since our arrival, we've had the worst healthcare, the worst outcomes, and the worst service delivery as it relates to any illness or any pandemic that has occurred. And I will stop there.
Thank you so much for that perspective. So I'd like to switch to Dr. Ellen Grant. We have you now. Oh, wait, I don't hear you.
Well, while Dr. Grant is pulling up, I'd like to make one point, if I may.
Sure.
I just wanted to, since I am OBGYN and GYN oncology, one of the things we're finding is that Black women who are pregnant or have delivered or in the postpartum period, we have preliminary data to show that Black women who are pregnant or in the postpartum period fare worse than white women in terms of mortality from COVID-19. There was a study done by the CDC where they looked at about 8,000 patients, and it showed preliminarily that women who are pregnant and actually contract COVID actually do worse than women who do not have COVID. And there's a limited amount of data that shows within that population, Black women do worse than whites.
Oh, yeah. Thank you. Thank you. Let's see. Let me see. Ellen, are you able? So someone just noted that there's a pin at the bottom of your screen. So I wonder if that's something that we can control. Let's see. So BWHS, I'm in the background, was wondering if there's, if we have another way with Ellen. Let me just see if there's anything. Unpin. Try, can you? No, not. Yes, I also have a pin. Right? we are certainly getting the all the little demons of Zoom today, this afternoon, right? To audience settings to unmute. So I don't think that that is exactly what's been happening with, no, unfortunately. So we're going to keep working on you, Ellen. We're gonna keep working on you. Sorry. In the meantime, for BWHS, can we bring up the remainder of the slides? And I'll just spend a moment talking a little bit about the study let's see, while this is coming into focus. So as Dr. Albert mentioned, we are in the Black Women's Health Study trying to study COVID. This was certainly given our cohort and the number of years that we've worked with this cohort, we felt that this was a wonderful and timely opportunity to try to add to the literature and what is known about Black women's experiences and health outcomes during this time. As Dr. Albert and Dr. Clayton have described, there are many reasons why African-American women are experiencing the health disparities that they are. The goal of our study is to again document the experiences and perceptions of Black women related to the pandemic. This is, asking questions about individual risk, what might be individual risk for COVID, but also trying to understand when going in for care, the level of care that's being given, and fairness and treatment. Was that you, Ellen? Did I hear you? No, oh, sorry. Sorry, okay. We also wanted to look at how COVID, whether it influences health after the diagnosis. So I'll allow Dr. Albert to talk more about that. And she did hint on this about sort of the long haul implications of individuals who have recovered. Not everyone has long lasting health issues, but a number of people do. And also to look at whether people who were taking certain medications prior to their infection, whether their risk was mitigated or made more extreme. So this study began at the end of August. We sent this out, links to our participants, to a subgroup of the Black Women's Health Study participants. It was sent out online. So, and the questionnaire was available online. And to date, about 11,000 Black Women's Health Study participants have completed our questionnaire. They've ranged in age from 46 to 94, with a mean age of about 60 years. And we are continuing to get this data in, and we will be sending a follow-up questionnaire at the early in 2021. So I think at this time, I want to just bring in a few questions from our audience. So there's been, some of you submitted questions in advance, and I'm going to give these to the panelists. Some have been addressed already. But one question that, at least in our pre-questions, that we got many inquiries about that, and that is certainly, do adequate levels of vitamin D help decrease severity of COVID infections? Is there any data on that, Professor Albert or Dr. Clayton? Are there supplements?
So the data on vitamin D is not available. I will say that certainly anytime there is a medical condition or a new condition, for that, any medical condition, and certainly cardiovascular disease, there has been always a groundswell to look at the relationship between supplements and certainly cardiovascular disease risk. I think it's really important for the audience to know, one, we don't have vitamin D data, in any substantive manner as it relates to COVID, but two, that as it relates certainly to cardiovascular disease, which is the #1 killer globally, that there is not a single supplement that is actually shown to actually decrease risk.
Thank you. Thank you.
There is
Another
some,
question.
there is
Mhm,
some, there is some
mhm.
debate about, a lot of people use zinc, for example, to help with, to presumably quote unquote help with, helping with infection risks with colds, flu, etc. Again, for zinc as well, the data are still out. Certainly our infectious disease colleagues are not dissuading people from using zinc, but there's no real supportive evidence either as
Yeah,
it relates to
so,
COVID.
okay, thank you. Another, and this came up a lot as well. Is there any credibility to reports that COVID affects certain blood types more than others?
Is that for me or?
Sure, Michelle. I'll let you take that one if you'd like.
Right. I will, sort of pivot the question. This is what we know about
Mhm.
COVID. We know that COVID infectivity is related to less so biological factors, although we know it does enter through the ACE receptor and the ACE2 receptor, and we know that that receptor is plentiful in our mucosal membrane, so like in the mouth, nose, and also the GI tract. We know that. However, your risk for COVID infection is related to the social determinants of health that you heard outlined. So
Mhm.
that's number one. Number two, the risk is also related to chronic medical conditions. So if you're an asthmatic, if you have cardiovascular disease, so you've had a heart attack, stroke, diabetic, or obese, at least 30% to 40% of Black women are obese, with about 70% being overweight. And these are things that really like drive your risk of complications from COVID. I saw a question in the chat about, and this is not so much about blood type, but it's about blood, right? About sickle cell trait and sickle cell
Yes.
and COVID, which is pertinent to our communities. Certainly, having sickle cell disease we know is associated with, there have been several NFL players, for example, who've had, sudden death. And we know that the trait, although like I think it's like 3 million Americans have sickle cell trait, 500,000 sickle cell disease, puts you at risk. Certainly, sickle cell disease puts you at risk for, sort of low oxygen, right? And so if you're infected, it is likely that if the disease process affects your lungs and affects your oxygenation, what you're doing is you're layering that on top of a chronic medical issue that you have, which is likely to increase your complication risk. So again, more data needed, but it wouldn't be surprised. It's not surprised. The data aren't surprising to me that if you already are prone to certain to low oxygen, for example, due to a genetic condition, that you would have heightened risk of complications.
Yeah. So along with that, uh, with the pre-existing conditions, type 2 diabetes comes up quite a bit. And there was a question about why specifically type 2 diabetes. Why is that something that has emerged as a pre-existing condition for COVID, or a risk factor, I should say. And Dr. Clayton, feel free to jump in as well.
Diabetes is, so diabetes, cardiovascular disease, asthma are all inflammatory conditions and have an inflammatory basis to them, as well as neurohormonal bases to them. And we know that, sort of throughout the course of this illness, that there are different phases of the immune response that are either hyperactivated and less activated. So again, it's no surprise that a process like diabetes that sort of is in part immunologically based, as well as neurohormonally based, would put you at higher risk.
Mhm.
Same reasons why diabetes puts you at higher risk for cardiovascular disease, for example, and higher risk for infections in general.
Okay, thank you. That's very.
Yes,
Mhm.
and this is Dr. Clayton. I would certainly agree with Dr. Albert. And I think it goes back to someone asked if there was a biological basis, and there is no known biological basis for having a higher risk of COVID, as Dr. Albert has mentioned before. But one of the points I think we need to kind of drive home on is, from a biological standpoint, we as human beings we carry the same, genomic profile. We all share 99.9% of our human genome with one another as it relates to our genetic makeup. So there are some specific diseases that are biologically driven, but most diseases are not. We are susceptible to disease as any other population group, but for the most part, for most diseases, we can say that there are multiple determinants, but it is not usually a genetic or biological basis unless there are specific diseases like sickle cell, thalassemia, several others, but the majority of diseases are not genetic based.
Mhm. Great. Another question has to do with preventive care. One of the major disruptions with COVID was people going in for their annual checkups, for their mammograms, colonoscopies, other things like that. What is the message for people? My gut is that we should not put off the preventive medicine, the preventive visits, but this has certainly made people very afraid. What advice or how would either of you respond to that concern?
Certainly, the Association of Black Radiologists, as well as the American Heart Association, have had messaging out there about not, delaying going in for, if you're developing shortness of breath, chest pain, stroke-like symptoms, any of those things, seek medical care. And the reason being is that you're still more likely to die from a cardiovascular, and I know I'm pushing this issue, and because it's true, that's what drives our death rates and drives our disparities, sort of related to race, ethnicity in terms of the outcomes. So please seek, go for help. We know that when you delay your care, and certainly I've seen this as I've been on the clinical services over the last several months, is that folks are coming in with more complicated, let's say, heart attacks. So they're not just only, and it's not just a heart attack, but instead of coming in with a heart attack only, folks are coming in with a heart attack plus a failing heart, or coming in with a heart attack, a failing heart, and needing to be intubated to go to the ICU. And this is, and so these are big deals, because this is going to, just affect you and your family and increase your risk of death and sudden death throughout your, for the future. And so the advice is, if you have symptoms that require medical care, go to the hospital. The hospitals have been taking extraordinary measures to provide their staff with PPE at this point. We're no longer early in the pandemic. Provide the staff with PPE. There are procedures in place to help mitigate your risk. Risk is never zero, wherever you are. But certainly the risk is extremely decreased. Certainly at my hospital, what is happening is that all patients who come into the emergency room are actually getting tested for COVID. And for patients who are higher risk, because a test today that's negative doesn't mean that you're going to be negative tomorrow. So patients who are at higher risk, because the incubation period for this thing is anywhere from 5 to 14 days. So patients can get retested, and the patients who are at higher risk coming in the door for a host of reasons are placed into isolation. And there's a separate level of PPE required for taking care of. There's person under interest, it's called, or someone with and someone with COVID.
Dr. Clayton, did you?
Yes, I certainly agree with Dr. Albert. And I think that taking care of ourselves, our families, keeping up with our appointments is extremely important. And there are circumstances, however, if your provider can do virtual appointments, unless you need lab testing or x-rays, et cetera, you may choose, if the providers offer, a virtual appointment. So there are some alternatives to going in, but try not to miss any of your preventive appointments, as well as schedule appointments for particular disease processes.
So we're going to try something now. Please bear with us. I have Dr. Grant on my cell phone, and we're going to see if you can hear her through this portal. So a question that was posed for Dr. Grant was regarding, has there been an uptick in Black women being treated for depression or mental illness during this pandemic?
Yeah, yes, in fact, there has been. Actually, in my former role, I was Commissioner of Mental Health for the county, but continue also as a clinical social worker therapist. And what we've been seeing is a number of not only depression and anxiety, but also alcohol, substance abuse, domestic violence increasing, child abuse in the general population. Certainly if you're a Black person who's unemployed and having a number of stresses financially, housing, etc., that is also adding to people being more prone to having mental illness and behavioral health issues. In fact, there's been a government survey that said 3 in 5 Americans were fearful of getting a COVID diagnosis. So certainly loneliness and isolation, particularly among our seniors, is obvious. But in nursing homes, what they're seeing is a different type of depression, which they're calling a pandemic despair among residents. In fact, I have a colleague whose mother was in a nursing home and she was doing fairly well, but because she couldn't see any of her family members because the nursing home was in high risk, had several COVID cases, she became quite depressed and really just literally died from sadness in her sleep. So I do think there needs to be more research going on in a lot of our facilities, particularly in mental health facilities where we have varying population. We're also seeing a number of people are reporting a number of very crazy, wild dreams during this pandemic period, and that's across the population. And some of you on the call may be experiencing that too. Some people having violent dreams where they're being chased or killed or drowning, all kinds of things like that. But I want to point to one of our listeners, a resource. Last month was World Mental Health Day. And if you just Google World Mental Health Day on YouTube, you will see a number of free resources, all under 10 minutes, that can help you with anxiety, meditation, some mindfulness techniques, how to really just calm yourself during this time. remember, so many things are out of our control. So we have to focus in on those things that we have within our control and try to find joy in every single day. Like, walking outside in nature if you can, certainly socially distanced, of course, but nature has shown to be very conducive to calming our mind and getting us in a better place. So I'll just stop with that for a moment.
Well, now I have a follow-up question for
Yes.
you. And so, the social distancing, wanting to be near people that we love and care about. How do we, I'm sure there is some stress when we have family members who perhaps don't want to either social distance or wear a mask, in the same way that we might. I'm sure that also leads to a stress. Are there some strategies around that as well?
Are you talking about different ways of wearing a mask?
Well, or of just sort of dealing with family members, right, who don't want to take the same precautions, maybe don't anticipate the same amount of risk that you do.
Oh, certainly. And they're out there. Every family has them.
Yeah.
You have to be mindful of self-care. And the only way to do that is just to say no. Don't let people in your house if they aren't going to follow your rules of keeping safe. People are preparing or getting ready for Thanksgiving. And, even Dr. Fauci has said it's going to be a different kind of Thanksgiving. Unless you're in a climate where you can be at a big picnic table or two and have some social distancing, be very, very careful. Because Canada has already shown in its research with their Thanksgiving, which is about a month before ours, that the COVID cases have spiked 2 weeks after their Thanksgiving because people weren't following the rules. Yes, we're all tired of the pandemic and the social distancing and the rules, but you'd rather have a mask on than a ventilator, believe me.
So sorry, I've just completed the Zoom thing with the dog barking now, so my apologies. I'm going to ask Delia if you could bring up the slides again, because we are at the top of the hour. Thank you. My apologies for the for the dog, right? Yes, he's been listening as well, right? Well, that this hour has gone by.
Dogs and COVID and cats and COVID too.
This is true. This is very true. But I really want to thank everyone who's joined us, our panelists, Dr. Michelle Albert, Dr. Linda Clayton, Dr. Grant. I'm so sorry that we couldn't figure out the technical things, but I'm so glad that we were able to hear your words towards the end. I just wanted to share a couple of things. And actually, can we go back one slide, please? Yes. So again, the BWHS study, if you've already completed a questionnaire, that we will be sending a follow-up questionnaire at the beginning of next year. If you received the link but did not complete the questionnaire so far, it is not too late for you to do so. But please, before certainly the end of this year, we would love for you to join the almost 11,000 women who have already contributed information. Next slide, please. For those who want to learn more about where COVID is each day in terms of counts, areas that are most effective, the Johns Hopkins Corona Resource Center is an accessible and very detailed place where you can go. This is just a screenshot. It's updated every day. It breaks down by state, and it actually has a global tracker as well. Next slide, please. Finally, there's another study in which our participants, Black Women's Health Study participants, have been making a contribution, and absolutely anyone can join this particular effort. This is the Zoe MGH COVID-19 study. The collaboration is between Mass General Hospital, Stanford University, and King's College of London, and it is open to anyone who either has a phone or access to a computer. It does daily symptom tracking. It asks various questions, but importantly, if you are in a study like the Black Women's Health Study, you have the option to link your information collected here with the information that you've provided us and the main Black Women's Health Study, where we send the big questionnaires every 2 years. You can see here a list of collaborators, other studies who are study members who have joined. So you can please go to this site here, the covidjoinzoe.com, and get more information, and certainly join if you are, if you wish. To date, about 1,700 Black Women's Health Study participants have joined and linked their data. Next slide, please. So as we wrap up, a couple of things. This will be our last live webinar for this year, but in December, we will be posting some links as we get into holiday season on healthy eating. During our last seminar, many of you asked questions about food and nutrition. So this will be our holiday gift to you, and so please check the website. You'll when we'll be posting links from demonstrated by the Boston Medical Center Teaching Kitchen. And next slide. And then finally, we would like to leave you with some inspiration. I know that the last time we closed, we shared with you the Interstate Gospel group from Boston University. And today we are tapping into another member of the Boston University family. We are closing with a poem written by Lucille Clifton, but the poem will be recited by Professor Crystal Williams. She is a poet and an essayist, and she's also the Vice President and Associate Provost for diversity inclusion at Boston University. I think you will like her contribution. Please take the words of Lucille Clifton to heart, and know that we will all be in this, we are all in this together, and we will all get through this pandemic together. Thank you so much for joining.